Hi everyone, my name is Dr. Fanindra Antaram. I'm a geriatric fellow with University of North Dakota, and today I'm going to be presenting a systematic review and meta-analysis paper on hospital at home interventions versus in-hospital stay for patients with chronic disease. Hospital at home intervention has been gaining more traction due to reduced overall health risks, better system costs and outcomes. It includes monitoring patients with face-to-face clinical care from nurses and/or physicians, having diagnostic testing and also IV medications available. The intervention is fitting for patients with chronic disease. The goal of this study was to minimize heterogeneity, which the previous meta-analysis and systematic reviews suffered from due to variable population, due to inability to distinguish between early discharge versus total substitute for in-hospital stay, having various points of entry such as from the community, ER, or during the hospital stay itself, and having differences in key components of intervention such as home visits, phone access, and coordination with home-based services. They've used the Prisma format as a reporting guideline. Here's a flow sheet showing the same. They did have extensive database search and had 9 databases. For inclusion, trials need to compare in-hospital versus hospital at home for patients having chronic disease, taken care of at least by one visit by a nurse and or physician, and at least one outcome related to clinical outcomes such as mortality, quality of life, usage of health services such as readmission to hospital and out-of-pocket costs, or processes such as length of treatment needs to be looked into. Obstetric population, mental health, and rehab populations were excluded. Patients needing long-term care, post-surgery services in outpatient settings, post-discharge interventions, end-of-life care at home, or if any self-care was given at home was also excluded. Review of studies for inclusion was done by 2 independent reviewers, and so was resolution of discrepancies. They have used descriptive statistics on continuous and categorical data. Relative lists and confidence intervals were calculated for binary data. They have used narrative synthesis for outcomes not amenable to meta-analyses. Sensitivity analysis for each outcome was done. Post-hoc subgroup analysis was also done for verification of specific components of interventions. They used the Phi risk of bias appraisal tool to look into biases. There was no significant difference in baseline characteristics. Mean age was 71, 63.9% were men. Mean population size of study populations were 104. Studies range from 2000 to 2018 in 4 different countries, and some studies had more ancillary staff. Listed here are the characteristics of studies. As you can see, there was only one US study. The outcomes that they looked into measure mortality, length of stay, readmission, and follow-up up to 1 to 12 months. As you can see, they did not see any significant difference in mortality. They did have lower risk of readmission and also long-term care admission in the hospital at home group, however did have longer lengths of stay in the hospital at home group. Individual chronic disease on analysis didn't show any difference in readmission rates, no significant difference in readmission at 3-month follow-up, no difference in outcomes when nurses and physicians see patients. In the outcomes narratively synthesized, you can see better patient satisfaction in hospital at home group and lower morbidity, however no difference in cognitive status and nutrition. One of the studies did show increased caregiver stress at the start, which however improved at the end. You can see improved mental health in hospital at home group versus in hospital patients. In home anxiety worsened, better quality of life at home, however other functional status and neurological deficits didn't show any difference. Based on the study outcomes, hospital at home is a recommendable alternative to in-hospital admission for limited populations, as they have similar mortality and readmission rates when compared. They also do have better patient satisfaction and mental health, and this is mostly for patients with chronic illnesses who have repeated admissions. Most of the limitations listed in the study were around heterogeneity, which is variation in the outcomes. The contributors listed are varied interventions such as phone calls, consultations, variations in patient characteristics, underrepresentation of women, the context of implementation such as location of study and also time of study, the smaller number of studies that were included. They did report the pool length of treatment, however they did comment about high heterogeneity in the same. Other limitations that I felt needed to be included here are exclusion of multiple studies to decrease heterogeneity, location of studies, omission of out-of-pocket costs, limited patient illnesses and the severity of illness, limiting application, not considering percent of patients who refuse the service of hospital at home, patient to healthcare personnel ratio, which is more in hospital at home, social support and availability of family for patients. Overall, hospital at home appears to be a reasonable alternative, although with limitations for elderly population with chronic diseases who utilize healthcare services more often than others. However, with difficulties in implementation due to in clinical practice due to need for extensive modification of healthcare systems. Thank you.